Now, Boston came up with a very nice workflow, and as you notice, for all imaging, now we are moving for what we call actionable imaging, where you have a clear workflow, clear step throughout the way to make sure that you do not miss anything, and the communication among the cath lab staff is very clear. So the workflow we're going to discuss is IVUS 123. So the case is a 77-year-old male who do have underlying coronary artery disease, previous CABG. All the grafts are patent, and he's having symptoms of shortness of breath, and he does have an indication for an angiogram. He underwent the angiogram, and the angiogram, as you can see, he does have significant diffuse coronary artery disease in the right coronary artery. And for those of us, I trained and practiced in an era where IVUS was very little in use. I could tell you this had been done before without IVUS. If any of you in your cath lab who does not have IVUS, this can be done without, but what did we learn over the last 5 years in terms of information to say IVUS or any type of imaging is better or not than plain angiography? So if we take the information that this simple angiogram tell us about calcification. Before we inject, we know there is calcification. Are we able to quantify it? No, it is not specific, but we can, if you see the arterial tree throughout the artery without a contrast injection, there is significant amount of calcification. The second part that we can achieve by looking at an angiogram is the luminogram. Tell us where is the most severe stenosis. So if you are to go and do an angioplasty without some form of real imaging, then you might end up with focal stenting, and you will not know whether or not you're truly covering the whole lesion. And this will be apparent throughout the session. So, in your cath lab, whether you are a technologist, a nurse, or a cardiologist, how many times would you use IVUS? Each case, certain case, or you don't have IVUS? Before stenting? So great. So if you look, he mentioned 3 important things in the post pathway. Yeah. So he already moved to the post PCI flow, which is things that we're going to discuss. But what about pre the PCI? Before we do the PCI, what's important information for you? What? Sorry, I missed. So you want to use left main because the consequences of malapposition or under expansion is significant in the left main. But I'm just showing you an RCA. So the extra information that you look for, which is where is my landing zone? This is so much diffuse. I'm seeing calcification, or there is something more than calcification, as we're going to discuss. And if there is calcification, what I'm going to do about it? I'm just going to take a stent and inflate it. So this is where imaging added more information to us. So calcification in the literature has been clearly shown to increase the risk of a PCI. That is fact. Increase the complexity of the PCI. So our job is first to identify whether or not I'm dealing with calcification. 2, what I'm going to do with the calcification. There are so many pathways, and there are some recent data published from TCT, but you could choose whatever way you want to use to modify that calcification. And what is important for me is what is the size of my stent, and where do I start, and where do I finish. All this information is available to us, but then the new things, or that the workflow that we should adopt is a clear pathway of 1 to 3 IVUS. What do I look for? What are the important pre and post? So I'm not going to bore you with data, but compared to when I trained around 2006 and 8, I could tell you that our use of IVUS was 5%. I look at my cath lab now, where I practice, our imaging is almost 40% of our cases, and it is destined to increase. Why? Because there is a clear data to show you that in complex pathology, like long lesion, bifurcation, left main, all these has been shown to have benefit by using imaging guiding. So we want to practice. So we're going to discuss the type of plaque, but it is very important for us to quantify calcification. Are we dealing with fibrotic or with lipid-rich plaque? It is also for us important when we use the workflow to make sure that we identify calcific plaque and define the area for measurement. Is it the external elastic membrane or lumen to lumen, which we're going to practice together. So let's see where is, so the pre-PCI pathway, you already mentioned all that, but what do I need from the IVUS? I wanted the IVUS to tell me what is the distance of my lesion. How would I decide? I decide by picking my distal reference and proximal reference. Well, any proximal or distal reference? No, we want a lesion or we want an area where we land the stent that has the minimal plaque possible. Ideally, it should be normal, but we cannot find that in a diffusely diseased artery. So we want to minimize that to at least less than 50% plaque. Why? Because the more diffuse disease at the outlet of your stent, the higher risk of target vessel revascularization. So information number one, what is the lesion length? Two, what am I dealing with? Is it a plaque, lipid rich? I do not need to do any modification. Is it mild calcification that I can deal with a non-compliant balloon or a carrying balloon? Is it severe calcification that I have to modify with a atherectomy device or with a shock wave? The last part is picking your stent, which is the diameter, and that is very important, and the workflow will go over that. So, just because I want to dig into the workflow itself, as we're going to cover those. So this is the run. I want the help of my colleague. Do you have the workflow? Do you have the first run? This is our first run before we did the PCI. So we said, what do we want from this run? Distance. I want to see what is my length of the lesion. Second thing, what is the degree of my calcification? Do I need to do anything? Do I need to modify? And the last thing, what is my stent size? So each one of you, through the workflow with the team, we're going to show you how to reach to that information before we move to the next step. So I'm going to find a way to slow it down so we can highlight a couple of things. So a simple question, calcified or non-calcified? Calcified. Very calcified. Okay. Concentric. Excellent. So look at the circle. Is it 360? So the second thing is very important for us. The IVUS cost. The IVUS catheter is very small, low profile. You want to find the next information. What is the minimal lumen diameter in the smallest area? Does the minimal lumen diameter big enough to allow me to cross with a bigger balloon, or I have to modify it with more information? That information is also available. Looking at the minimal area, the smallest now. What is the smallest area? Mustafa, can you point it out? So let's pick the smallest area in the run and look at it all together. The smallest area in the run. So with a lumen area less than 2, absolutely you can try to modify the usual way, smaller balloon and build yourself, and then you could use a cutting balloon. The pathway though here has been established to look at specifically whether you have a lumen area more or less than 2. If it is less than 2, probably you're going to have tough time passing an angiosculp or a Wolverine balloon. Then you have to think about rotablation. But let's say the minimal lumen area, the minimal lumen diameter is more than 2, you could absolutely write in trying with cutting balloon, non-compliant balloon. But the expertise in your cath lab in preparing the lesion has to follow a pathway. That pathway, based on the recent data, I could not tell you for sure that it has to be rota, it has to be the high pressure balloon or a cutting balloon. But there has to be a way for you to debulk that calcification, because the worst thing that can happen is to put a stent in a heavily calcified area and you end up with an underdeployed stent. Underexpand. This is what we are trying to prevent. So the pathway in here, for example, can include a rotablation, cutting balloon, or if the lumen diameter is big, you can go with a shock wave. The issue with the shock wave, there is definitely a newer data that shows no difference between it and a non-compliant balloon. But more importantly, it is more applicable when you have a focal calcification, that ring of calcification that you're trying to modify. If the shock wave cross, it is able to modify. But if you have diffuse calcification, maybe this is not the best use. Rotablation is an option. So the message here is you use the platform to decide what you are comfortable with to debulk. So what is more important once you debulk is to look what was the strategy you used and what does it translate into at the IVUS. If you use an non-compliant balloon, if you use a shock wave, what we're going to look for when we repeat the IVUS, I want to see cracks. It is very important because those cracks indicate that you're able to expand the balloon and you're able to have a stent that is expanded. So this is an important aspect. You might not see such modification except for the crack if you are dealing with deep calcification. Deep calcification need maybe a shock wave, maybe a non-compliant balloon or a high pressure balloon. But let's take the example here that in this case we used debulking, and the debulking was a rotablation. I'm just going to skip to that because I want you to identify in the run what is, yes, so see, even me that I use IVUS, if I did not follow the pathway, I will forget. We spend the time looking at calcification, our minimal lumen, but we did not discuss what is the length of our lesion and what is the reference diameter. So I just need the help of the team to highlight how is the lesion length. How did we reach to a lesion length of 90? Very important that each user identify how did we use to this. And the second part, at the distal reference diameter, just show how did we reach to 2.5 and 2.7. It's a range. So here we are at the distal lesion. This is correspond to the distal lesion, and you see a minimal 2.5 to 2.68 or 2.7. So you can safely use a 2.7, 2.5 or 2.75. The proximal 3 to 3.6, and we will discuss the choice of stent in a second, but it is very important that anyone who's using the station to understand how did we reach to the length and how did we reach to the reference vessel, distal and proximal. By the way, it is automated, but still we have to, AI does work, but we still, sometimes we have to be human. So now we did our rotablation, non-compliant balloon, whatever modification you decided to use. It is very important to have advantage, to take an advantage of the same IVUS catheter to tell you as an operator, well, did my modification work or I need to do something more? For example, 1.75 per, and it did great shaving, but did it really induce some cracks or not? So there is the second IVUS run we're going to discuss is for one purpose. We already had the initial 1, 2, 3 information. We know about our distance, 99. We know about reference or proximal. We know about the composition. We took the initiative to do rotablation or whatever debulking. Now the second run becomes important, especially when you are dealing with diffuse disease, to see the effect of your debulking mechanism, cutting balloon or rotablation or whatever. So let's look at the second run with one intention to show where you see the difference, and that is very important. I'm gonna stop it where I think there is an area. So what we're looking for is cracks, any areas of cracks in the arc of calcification. So this slide shows it, but I want you to reach to the same frame to understand it, and you see the difference between this and the previous run. So long that they can see the cracks in the calcium, which is very important.
More than?
So I ask a question. Should we stop here or should we do an uncompliant balloon, or would you just rotablate and stent, or what do you do? Yeah, usually most of the time we do non-compliant balloon dilatation after the rotablation to ensure that we have a unified dilatation and ensure there is also easy crossing, because sometimes the rotablation cross easy compared to the balloon. So it's very important. So how does IVUS help us, guys, in deciding the balloon size? You do have your distal, the area of the distal reference diameter. When you are dealing with the post dilatation, it's very clear. You don't want to surpass or use a balloon more than external elastic membrane. But for the pre-dilatation, you could use the same rule -3. So that's absolutely, you can use that for the pre-dilatation. So now, You pre-dilate it. You are ready to choose a stent. What stent we should use here? A length is 99. I'm not going to bring the drug-eluting balloon argument because there's an argument for that. But let's say you want a stent so we can demonstrate the post-processing for the PCI with the stenting. Is there any stent that is more than 90 or like 90 millimeter? So we got to use two stents. So a 275 at the end and a 3.0. We're going to go over now the angiographic result. And I'm going to see, just 1 second. 2.5 to 275. And the reference area approximately is 3 to 3.5. Okay, so synergy, if you took a 2.5 synergy, how far would it go? But the 2.5, how? So, within the stenting, you want to pull the IVUS again. I just want you to tell me what are the information you are interested in. Yes? So there is, it is part of the 1, 2, 3. So there is 1, 2, 3 for pre-PCI, and there is 1, 2, 3 for post-PCI. It is very important that when you observe your stent in the outlet and the inlet, the immediate thing we look for is dissection. We are trained that way. But it's also important that you do not have any geographical miss. Our understanding of geographical miss is always an area between the two stents. But a geographical miss can also be missing the plaque. So you are landing the stent in an area where there is a plaque burden more than 50%. The other important information, you want to see the stent attached to the wall or the plaque in that area, that is which is a position. And more importantly, you want to see that the stent is expanded. And that's when we're going to spend time about expansion, because this is an area, for example, in OCT, it's immediately give you a number or reference number. Same thing, it calculated the number based on the distal reference. And you could follow it easily, which we're going to discuss when we come to the post-PCI platform. Okay?
Ideally, you use the same approach that you used before stenting, or you replace the
For IVUS?
Yes. The same approach?
So that is one of the advantages. I mean, to be fair, we use also adequate OCT and IVUS in our lab. When you do a complex PCI, you find that you are using the catheter up to 6-7 times, and we reach out for an IVUS rather than an OCT sometimes because of our concern about the contrast. But unless you kink the catheter. So this catheter, to be fair, comes with a superior deliverability. We understand that part. But if you are not careful, it can be kink, but it is very rare. 6, 7, 8 times, wherever you want to use this catheter, same catheter, so long that you flush it and you make sure that you align it before you use it again. Okay, so let's go immediately, because this is I think the crux of this session. We want to make sure we have seen 2 runs, ya shabab. Now we are going to the final home stretch. What we are looking for, we want to look for dissection. So we're going to look at the distal and the proximal. We want to look throughout the whole stent and look for our minimal stent area, a position, and then we look for our expansion. So spend some time in the run, and the new software really comes with a very great feature, which we will. So, when you are assessing the distal edge, you definitely want to switch off the AI. You want just a 2D view to make sure that there is nothing obstructing the view for you. Similar criteria for highlighting a significant edge dissection, more than 3 millimeter. Second information, we want to see, are we landing in a good zone or not? Usually, if you are landing within 5 millimeter from a black that is more than 50%, it's okay. But if it is less than 5 millimeter, you might alter your strategy. Probably you want to cover that area. So that's number one. We're going to scroll, which I don't have the ability for, but each of you is able to scroll throughout the stent. Are you able to scroll from distal to proximal? Because the first thing is you look at the glans and see whether there isn't any area that caught your eye with a smaller minimal stent area. And then you could add the AI and it will tell you in each area what is your minimal lumen area, as you could see here, the one number in yellow. So try to move it from distal to proximal and see if you get anything below 5.5 when RASI. And then we will discuss the 80% rule.